updates on influenza, RSV, and COVID-19. These are my disclosures, and these are the objectives of my talk. We're going to first define the epidemiology of RSV and influenza since the COVID-19 pandemic. I'm also going to describe vaccine recommendations for both influenza and SARS-CoV-2 so that you can better advise your patients about these vaccines. I'm also going to identify treatment options for both influenza and SARS-CoV-2. Because we're going to be covering a lot of ground, I think the easiest way for us to go through all the information is to do it virus by virus. I'm going to start off going over influenza. Then we'll discuss RSV, which is going to be the shortest section, and then we'll go through COVID-19 updates. So I think like a lot of you towards the end of the summer, I was feeling really good about COVID, especially because of the fact that the new bivalent booster had come out. And then of course, as fall progressed, started seeing news headlines sort of indicating that there was something new going on. And that is a triple-demic. So there have been all these news stories that have been coming out about convergence of flu, RSV, and COVID-19 this winter that's going to cause a lot of strain on our healthcare systems and on us as physicians and people within society. As sort of like an introduction to this, so this is data from the Seattle flu study, essentially showing that prior to COVID-19, we had ebbs and flows of respiratory viral illnesses. And then COVID-19 came along and we all remember the lockdown, of course. And after that, you can see here on this graph that we really had a drop in respiratory viral infections that stayed in place as masking, social distancing, travel restrictions continued. And as these things began to be lifted, we see that there were increased rates of all of these different infections, which brings us to today. And it's not just in Seattle, this is happening nationally. Here we can see that there have been record lows of both influenza and RSV during the year 2021, as well as 2022. This is data from MMWR, which reflects our national data. So with that in mind, I think that it's important that we go over this because there's essentially an entire birth cohort, so people ages 0 to 3 who've never been exposed to any of these viruses. And on top of that, there's also a cohort of trainees who haven't really had to take care of a lot of patients with either RSV or influenza. So to start things off, I'm going to go over our tried and true friend, influenza. I'm going to go over the current rates of influenza within the community. Then we'll go over vaccines, followed by the symptoms so that you all can recognize, just as a review, what people who present with flu may look like. We'll go over diagnosis, and then we'll go over the treatment as well. So already at the beginning of this flu season, we're seeing a lot of cases. There have been the CDC estimates anywhere between 4.4 million to 9.8 million episodes or diagnoses of flu. There have been substantial hospitalizations as well as flu deaths. And to put it in perspective, this is like the weeks of the year on the x-axis, and then this is rates of hospitalizations. And you can see that we're at a higher point this year than we typically are during normal influenza seasons. The only time where we've had higher rates of flu was during the H1N1 pandemic of 2009-2010. On top of that, we're also seeing lower rates of vaccination against influenza. Compared to the previous 2 years, there have only been 150 million doses of the vaccine distributed compared to 163 and 181 during prior years. And I think that it's really important to stop at this point to sort of go over what it is that we should be informing our patients about in terms of getting the flu vaccine. I think a lot of people will tell us, like, it doesn't matter, I still get the flu anyway, I still end up getting sick and it sucks. Well, what doesn't suck is that it actually getting the flu vaccine prevents your rate of cardiovascular events. This is a meta-analysis published in JAMA in 2013, just showing that people who were vaccinated against flu were less likely to have some sort of cardiovascular event when compared to cohorts who received placebo or like a control vaccine. Similarly, it decreases your rate of hospitalization. Regardless of the year that's been studied, from 2018 to 2019, 2019 to 2020, and 2010 to 2014, we see that people who get the vaccine are much less likely to be either hospitalized or put in an ICU because of severe influenza. So let's go over the components of the vaccine. All the vaccines that are currently available right now are quadrivalent, meaning that they infer protection against 4 different subtypes of the flu. They're influenza A, H3N2, influenza A, H1N1, and then 2 different influenza B subtypes. For persons who are 65 years and older or older adults, we recommend a different set of vaccines for them. In particular, we recommend these higher dose vaccines, which have 4 times the antigen concentration. There's also the option of a vaccine that has an adjuvant in it or a recombinant vaccine. The idea being that patients who are older generally have a little bit less robust of an immune response to vaccination. So they do require a little bit more of the vaccine to have the same type of response somebody who's younger would have. These are all the different vaccines that are available on the market currently. And I would like to point out that for our older adults, these are the 3 vaccines that are available and that are recommended. Underneath of this, you'll see this eggs-based live vaccine. Just as a reminder, please do not give this to your immunocompromised patients because we really do not recommend live vaccines for immunocompromised patients. The other thing that I want to point out about this live vaccine is that it's administered nasally. So it's almost like if you guys have used Flonase or any sort of nasal spray, you just like shoot it up into your nose. If you were to test somebody within like the first 7 days after receiving it, they may test positive for flu. So just keep that in mind that if you are testing somebody for influenza, that you just ask to make sure what vaccine they got. In terms of vaccine efficacy, there isn't a blanket statement that I can give to you all to say like, yes, this year it's going to be 98% effective. And that's because efficacy varies based on the flu type or the subtype. Efficacy is higher for influenza B and for influenza A, H1N1 virus than it generally is for influenza A, H3N2 virus. And the reason that is there are 2 different big reasons. The first one is that influenza A, H3N2 undergoes frequent genetic changes while it's in circulation compared to other subtypes. And so there can be some drift and changes so that towards the end of the flu season, it may not look quite the same as it did at the beginning of the flu season. The other thing is that a lot of these vaccines, we end up growing, the manufacturers grow the virus within eggs. And within the eggs, H3N2 is known to undergo some egg adaptive changes, meaning that there are these mutations that do occur that end up in making the virus slightly different from the wild type virus that they are trying to create. And this can mean that it drifts away from what it is that the manufacturers are trying to target. But all that being said, and then on top of all of this, the vaccines end up being selected for, the subtypes end up being selected for based on forecasts. I think something that's very notable is because we've had such a drop in influenza cases, we've also seen a drop in diversity of influenza that's in circulation within the community, thus making it easier for manufacturers to pick out which is going to be the most likely circulating strain of influenza, because there are just fewer flu viruses in circulation. So you can see here that there's almost this bottleneck effect thanks to the COVID-19 pandemic and all of the social distancing we were doing. In terms of efficacy right now, currently the most frequent circulating strain is the influenza A H3N2. About 70% of influenza is that strain. 22% has been identified as influenza A H1N1. And luckily enough for us, the vaccine actually is a very good match to the H3N2 that's in circulation. I'm going to move on now to transmission and to clinical manifestations. In terms of transmission, it goes from person to person via droplets. You may see some references that question whether or not fomites play a role. I really don't think that they do. As an aside, I did get flu as a first-year fellow and got to leave work early. It was so wonderful. But my co-fellow came, used my computer, wore my white coat, did everything she could to get flu by touching all of my surfaces, and she was completely healthy. So I really don't think that this is something that's transmitted via fomites. And you can see that via the fact that we don't require any sort of contact precautions when you do take care of a patient with influenza. So you're just gonna need to wear your surgical mask, wear your gloves and stuff, but really you don't need to wear the full yellow gown or anything else. In terms of symptoms, symptoms typically occur very abruptly. It's one of the hallmarks of flu. I know sometimes with COVID and with RSV and other upper respiratory viral infections, you're kind of like, am I sick or am I just like being a hypochondriac or a little just worried? Is it just a tickle in my throat? But with flu, it is abrupt and it's immediate and you know that you're sick. And typically the hallmark of influenza is that the systemic symptoms are just so awful that they kind of mask the respiratory symptoms. So people will complain about fevers, chills, headaches, myalgias, malaise, and like loss of appetite. And then they'll also have a little bit of a cough, some sore throat, but that really isn't what they're coming to you complaining about. It's all of these other symptoms. And then about 3 to 4 days into illness, the systemic symptoms subside, and then you end up with just a little bit of a lingering cough, sore throat, etc. Flu can progress to a lower respiratory tract infection, and it can also result in very severe disease. And I think it's important for us to know who are our patients who are at risk for severe influenza. So these are people at the extremes of age. These are people with chronic medical conditions like COPD, diabetes, heart failure. Our immunocompromised patients, so our bone marrow transplant recipients, our solid organ transplant recipients, anybody who's on any sort of like immunologic agent, they're at higher risk for complications and severe illness from the flu. I'm also going to point out that certain racial and ethnic minorities have been found to be at higher risk for complications of severe influenza, whether this is a product of health disparities or like lower rates of vaccines, like the MMWR has pointed this out, as has the CDC. So it's just something to be aware about in the back of your mind. The flu has a lot of complications associated with it. In terms of upper respiratory complications, these typically occur in children, and it's usually secondary to a bacterial superinfection. Lower respiratory complications include pneumonia and ARDS. Cardiac complications, I really want to highlight because there has been a lot of research into this, but essentially any of your patients with coronary artery disease are at higher risk for myocardial infarction, as well as for heart failure. And then the musculoskeletal, myositis, rhabdomyolysis can also occur. And then neurologic, the big one that I want to point out is GBS or Guillain-Barré syndrome. So the reason I'm pointing this out to you is that I think a lot of our patients sometimes express a little bit of concern about Guillain-Barré from influenza vaccination itself. You're actually at higher risk for Guillain-Barré with influenza, like a de novo infection, than you are with the vaccine itself. The risk is low for both, but it's about 10 times higher with infection with the virus as opposed to vaccination. So it's like, to compare it to COVID-19, it's the myocarditis fear that a lot of people have with vaccination. It's actually much higher. You're more likely to get myocarditis from a COVID infection than you are from the vaccine. That's similar to this with GBS, where you're more likely to get GBS from an influenza infection than you are from the vaccine itself. And then in pregnancy, this is a major issue. So please make sure that your pregnant patients get vaccinated as well, because it can lead to premature labor and fetal loss. In terms of the testing that is available at Georgetown, we have two different tests. There's the rapid antigen test, and then we also have molecular assays, or the NAT testing that we do. The rapid tests are great in the setting of a uptick in influenza. So when there's a lot of community spread, these tests are fairly good. They have decreased sensitivity when compared to the assays, but if you need a rapid answer, it's a good test to do to get your answer. I will say though that if you can take away one thing from this, if you are admitting somebody and they're coming in with flu-like symptoms and their rapid is negative, the rapid antigen, I would just counsel you to make sure that you get a RVP on them, just to make sure that it truly was a true negative and not a false negative, which occurs more commonly with the antigen tests. So that brings me to my next point, which is who should be tested for influenza. Essentially, the people in the outpatient setting, it's anybody who it's going to influence your management. So in this case, it's really our immunocompromised patients, our solid organ transplants, our hematopoietic cell transplant patients, and those who are at high risk for influenza like illnesses, and patients who are at, it's for our solid organ transplant recipients, our immunocompromised patients, people with COPD, et cetera, who come in with an influenza-like illness or URI symptoms. Those are the people who we should be testing. The other group that you should consider it for is anybody who comes in with an acute onset respiratory symptom and exacerbation of a chronic medical condition. So an example of this would be like your diabetic patient who's typically very well controlled, but comes in or calls you and says like, hey, my glucoses have been like through the roof and I have a little bit of a cough, like what should I do? That's somebody who you should immediately think of influenza for, especially during this time of year when there's so much in the community. In the inpatient setting, it's all patients requiring admission with any sort of acute respiratory illness, anybody who has an acute worsening of a chronic or cardiopulmonary disease, and for any immunocompromised or high-risk patients, high risk of complications who present with any sort of respiratory symptoms. And these patients may or may not have fever, so you should have a really low threshold to go ahead and test them for influenza. In terms of treatment, it should be prompt for those who have severe disease and those who are at increased risk of influenza complications. So that includes those who are hospitalized, like if you're waiting for the test, just give them the dose of oseltamivir. Any outpatients with complaints of progressive illness of any duration, and outpatients who are at high risk for influenza complications as well. In terms of treatment, there are 4 different drugs that are available, but effectively there are really only 2 that we use in clinical practice. The first one is the one that we all know, which is oseltamivir. It's an oral medication given twice a day for 5 days. It's a neuraminidase inhibitor. It's been studied and found to be safe in pregnancy. You can also use it in our immunocompromised patients as well. There's a little bit of a caveat saying that if a patient is immunocompromised, it's up to the prescriber's discretion if you want to extend it from 5 days to 10 days. And then complicated or uncomplicated influenza, it's also the preferred drug of choice. The newer drug that is now available for outpatient treatment is baloxavir. This is an oral medication, and the benefit of it is it's a single dose. So they only need to take it once and then they're done. It's a cap-dependent endonuclease inhibitor. It's not recommended in immunocompromised patients because of the concern that there can be sort of this like tail effect with the drug, where our immunocompromised patients are thought to have viral replication for longer periods of time than our non-immunocompromised patients. And the thought is that you end up getting like less and less levels over time, and then that predisposes those viruses to mutations, specifically at like this P138M site. It's not been studied in pregnancy, so it's not recommended for that. And similarly, because it's this single dose and because of concern for this tail effect, it's only recommended in uncomplicated outpatient influenza. And Both of these drugs have their best efficacy when it's administered early, which means that it needs to be given less than 2 days from symptom onset for it to really show its magic. Oseltamivir reduces illness by 1 day and tends to reduce lower respiratory tract infections. Treatment with oseltamivir, so this study that I'm showing here, or sorry, in general, usually it has to start within 36 hours of symptom onset for you to get that 1 day reduction in illness benefit. It can also reduce lower respiratory complications, including bronchitis, pneumonia, and lower respiratory tract infections as well. In terms of baloxavir, its best efficacy is actually against influenza B. It's actually been found to be more effective when compared to both placebo and oseltamivir in terms of shortening the duration of illness. And with that, I'm going to move on to RSV. I'm going to first start off by talking about the current rates of RSV. I'm going to then go over the symptoms, the diagnosis, and then treatment and prevention. So these are the current rates of RSV-related hospitalizations. I think that if any of you have young children at home, you're going to see that if they were sick in the past couple of weeks, they probably had RSV. These are obviously rates that are higher than what we've seen in the past. It is transmitted via droplets that enter via the mucosal membrane after close contact or by self-inoculation when it is something that can stay stable for several hours on hard surfaces and on hands, which is why if you do have a patient who you're caring for with RSV, it's recommended that you, we do recommend that you wear the surgical mask as well as the gown, so contact precautions on top of the droplet precautions. Symptoms usually occur 3 to 5 days after exposure, and typically it begins as an upper respiratory tract infection with nasal congestion, rhinorrhea, sore throat, and from there it can then progress to a lower respiratory tract infection, manifesting as cough, wheezing, and dyspnea. And then it can further progress to a more severe disease, which results in pneumonia, acute bronchitis, and or a COPD asthma exacerbation. The people who are at high risk for this severe illness are people who have underlying lung diseases, people with cardiovascular disease. And although I have immunosuppressed patients listed here, the real big group that we worry about are our hematopoietic cell transplant patients and our patients with lung transplants. Our kidney, our livers are less at risk for some of the severe manifestations of RSV, and then the elderly as well. This is a slide that was made by our little fellow Sam in terms of how we make the diagnosis of RSV. In adults, really the only test that you should be ordering is a PCR test because it is the most sensitive and specific test. The rapid antigen test, on the other hand, is only approved for use in people less than 20 years of age because these patients who are like younger tend to have higher viral loads and higher antigen production as a result. So this test ends up being better for that group because of the faster turnaround time and because it's just more accurate. In terms of treatment, there really are not good treatment options for patients. Ribavirin, which is a guanosine analog, is something that we do give, and it is essentially available in an aerosolized formulation, which is the formulation that's approved by the FDA, only to treat RSV in pediatric patients. You can see here I have there's a little baby and he has a little tent over his face in which he's getting the aerosolized ribavirin. In our hospital, if we were to treat somebody for RSV, we would give the oral formulation. It's an off-label use, and it's really only something that has good evidence for in our hematopoietic cell transplant recipients, and it's all retrospective data. I want to point out also that the aerosolized formulation costs about $20K per day for administration, whereas the oral administration is like less than $100 per day. And the point of treatment is really to prevent transition from upper respiratory tract infection to lower respiratory tract infection. So if you have a patient who already has cough, already has like a consolidation on imaging, has oxygen requirements, at that point, giving them ribavirin isn't going to make any difference in their outcomes or make them get better sooner or anything else like that. Really, the purpose of treatment is to prevent that progression from upper respiratory tract symptoms to lower respiratory tract disease. I also want to point out that it is extremely teratogenic, and that, you know, as a fellow, we did give the aerosolized formulation, and as female fellows, we were not allowed to go into those patients' rooms because of the fact that it is so teratogenic. And then I also want to point out for our med-peds folks who may be in the audience that pelizivimab is a monoclonal antibody that's given to premature infants on a monthly basis. And it's also given to our immunocompromised children as well, who are at high risk for severe RSV, to help prevent the development of infection. Although that this drug is available for that, there's not really any data to say that it's helpful for treatment of adults or in children for RSV. I also want to point out that it's dosed based on weight, so it also becomes exorbitantly expensive the older or bigger the person is. There are several drugs that are currently being evaluated. And they all work at different parts of the RSV virus, either preventing fusion into the cells or preventing viral replication. And then I just want to point out that in terms of prevention, other than the monoclonal antibody that I mentioned earlier, there are some vaccines and other monoclonal antibodies that are in the pipeline. I want to point out also that most of the vaccine efforts and such are targeted towards the elderly patients, because remember, those are the people who are at high risk for severe disease, as well as maternal patients. So people who are pregnant, the thought is that if you vaccinate them, that there'll be transfer of antibodies to the fetus. And then if the baby is born early or is premature, that they still will carry that protection given by the IgG from the mom being vaccinated. And I'm going to close out now by discussing COVID-19. I'm going to go over some vaccine updates, testing, and treatment. So just to point out, for the primary vaccine series, so Janssen & Janssen, not recommended, just because it had like this large association with thrombocytosis in young women. Instead, if you have a patient who's very hesitant to get an mRNA vaccine, there is the protein subunit vaccine, which is manufactured by Novavax. And this is available, it's 2 doses of the medication, both for non-immunocompromised and immunocompromised patients. We also have the mRNA vaccines. And just a reminder, if your patient is immunocompromised, it's recommended that they get 3 doses of the primary vaccine series, and compared to the 2 that the non-immunocompromised patients are recommended. The bivalent vaccines are now out and available. It's a 3rd dose for people who are non-immunocompromised, and it's basically a 4th dose of vaccine for those who are. I'd like to point out that if you have not completed your primary vaccine series, you cannot just get the bivalent vaccine to complete that series. It's recommended that you still get the monovalent vaccine. And this is also particularly relevant for our bone marrow transplant recipients, because, you know, they all get revaccinated again after they get their engraftment and they're, you know, doing well and discharged. You can't just give them the bivalent, 3 doses of the bivalent. They recommend that you actually restart with the monovalent and then give the bivalent after that. So in terms of the FDA EUA for these bivalent boosters, just as a review, the mRNA in these vaccines instructs cells to make a distinctive spike protein of the original viral strain, as well as the Omicron variant lineages, BA4 and BA5, which they share the same spike protein. Data in humans for the Moderna bivalent and the Pfizer bivalent vaccine are still being collected. And they actually, both of these companies were able to get their EUA based on immunogenicity and safety data from clinical studies of another booster that they had initially been studying, which contained the original viral component as well as the Omicron lineage BA.1. And essentially what they did was these manufacturers went to the FDA and said, essentially, here we have the safety data for this, like it's like a proof of concept, like we have safety data for this BA.1 original strain vaccine. We would like to just substitute out the BA.1 component for this BA.4, BA.5 component. And because there's a precedent set with this, with influenza, the FDA went ahead and gave them emergency use authorization. So Moderna has their data published already in New England Journal of Medicine regarding the BA.1 vaccine. And so this is just showing that patients who end up with the vaccine or with the bivalent booster, when they do get it, they have higher antibody titer responses compared to those who just get another dose of the monovalent vaccine. Pfizer has yet to publish their data, but this is from the meeting where they presented their data to the ACIP. And essentially, they're just showing that patients who got their bivalent vaccine had a 9.1-fold increase in neutralizing activation or neutralizing activity compared to those who got just another dose of the monovalent vaccine. Moving on from vaccinations now, I'd like to go and talk about antigen testing or home testing. If you notice, I didn't put any of the data relating to COVID-19 rates within the community, and that's because a lot of people are now relying on home tests to make the diagnosis. And so I don't think that the numbers that are represented within the like nationally available forecasts are necessarily reflective of what's going on in the community. But that being said, I think it's really important that our patients know how to take these tests correctly. So say you have a patient, they are concerned that they have COVID, they test positive, great, they have COVID. If they test negative, you're going to need to advise them to repeat their test 48 hours later. And if there still is some concern for COVID-19, you can either repeat the home test again or have them come in for NAT testing. If they say that they've had a COVID-19 exposure, it's very important that you have them repeat the test at 48 hours. And if that's negative, they repeat it again for a third time. So 3 total tests in order to say that they're in the clear from COVID. During this testing, as long as they're testing negative, they do not need to be on isolation because the idea is that they are not infective to others if they have a negative antigen test. And then if they do test positive at any point, if they qualify for treatment, it's recommended that you treat them as well and that they isolate. I just want to explain this in a little bit more detail and why we have these recommendations. So this is a study that was done out of the California and Colorado health departments at the beginning of the COVID-19 pandemic, where essentially they had patients who tested positive for COVID. They sent them home with additional tests to test themselves daily. And they also sent tests home to their household contacts as well so that they could test themselves. Day 0 represents first day of symptom onset, and then they followed them throughout for 20 days. And then you see this -5 because these are people who are the household contacts who were asymptomatic, also got themselves tested during this period. And essentially what they found here, you can see, is that the viral culture, which is generally our gold standard, and the PCR generally tend to correlate very well at the beginning of illness, whereas the antigen test tends to lag. And this is why, and you see it's really only around day 3 that the majority of patients with COVID will have a positive antigen test. And so this is why we recommend that even if you have that first negative antigen test, you can't trust it. They have to repeat it again. Similarly, or conversely, in terms of following testing after that initial illness onset, the antigen test actually tends to correlate very well with with the cell culture or with the viral cultures. So that's why you'll sometimes see us as ID ask for antigen testing to be done on some of our immunocompromised patients, with the idea being that, they were symptomatic 10 days ago, their PCR is still positive. If they have a negative antigen test, we can say that they're not infectious to others and we can take them off of isolation. And then the PCR test remains positive for a very long period of time afterwards. The CDC, in terms of isolation, they recommend that patients isolate until day 5. After day 5, you can actually go out into the community as long as you're wearing a mask. And then at day 10, they say you don't need to wear a mask anymore. But I'm just going to point out that viral cultures tend to be positive still in more than 40% of patients on day 5, and a little bit like around 15% of people on day 10. So even though people don't necessarily need to isolate, they can still be infectious. And I would just warn your patients about this as well. And then for our immunocompromised patients, we say that, stay isolated until day 20 and then confer with an infectious disease colleague as to whether or not they can come off of isolation. And so this has been all over the news recently, that there are all new sorts of variants. This is the forecast, or the prevalence of the different variants that are in circulation right now. We went from a predominantly BA.5 COVID-19 to having BQ1 and BQ1.1. And this is a big deal because all of our monoclonal antibodies are ineffective against BQ1.1. And so that includes everything from bebtelovimab to silgavimab, tixagevimab, which is our pre-exposure prophylaxis monoclonal antibody that we've been giving to our immunocompromised patients. And as of yesterday, the FDA actually pulled bebtelovimab from across the nation, saying that we should not be giving it to anybody because of the fact that it's no longer effective against the majority of variants in circulation. As an aside, you may be asking, well, Rebecca, what about Evusheld or tixagevimab, silgavimab? Currently, because there's a lack of an alternative agent, the NIH is actually still recommending that we continue to administer this, essentially saying that it's used as COVID-19 pre-exposure prophylaxis in patients who are not expected to mount an adequate immune response to COVID-19 vaccines, or to those who have contraindication to the vaccine. In the absence of an alternative option for pre-exposure prophylaxis, the panel continues to recommend the use of tixagevimab plus silgavimab as PrEP for eligible individuals. That being said, for any patient who comes into our clinic to get this, we advise them that the majority of circulating antibodies are, circulating variants are not susceptible to this, and that they are still at high risk for severe COVID-19. In terms of treatment for COVID, it's recommended really for older adults, people who are 50 or older, and the increase for severe COVID increases with age. Anybody who's unvaccinated, and people who have chronic lung disease, heart disease, CKD, diabetes, or chronic liver disease, which is like most of the patients we end up seeing here. And then our immunocompromised patients as well. So what treatments can you use as an outpatient? Well, bebtelovimab is no longer available for us. So that leaves us with 3 options. So there's nirmatrelvir and ritonavir. This is really the first choice agent at this point because it's oral. You can prescribe it to your patient. They can go home and take it. The caveat to that being is that there is major drug-to-drug interactions associated with it. If you are planning on prescribing this for a patient, I would just recommend that you make sure that you have an accurate list of their medications. And then I usually go to the Liverpool website. If you Google like drug interactions, Liverpool COVID, it'll pop up. And then I input it there to make sure that there are no drug interactions. You should not be prescribing Paxlovid to anybody who's on tacrolimus. So please do not give this to any of our transplant or solid organ transplant patients. The Second best option, I think, is remdesivir. So we all know this from the inpatient setting as a medication that's given for 5 days in a row to help prevent progression of COVID-19. It can also be given as an outpatient, and I'll give you a little bit more information on that in a moment. And then there's also molnupiravir, and I just want to caution that this cannot be given to pregnant people. So remdesivir is now, different locations are setting up remdesivir infusion centers. We're going to be getting a memo. I don't think that the memo has come out yet with the 3 different locations where you can refer people to get IV remdesivir. It's about a 30 to 90 minute long infusion. Patients need to go to that site 3 days in a row in order to complete the treatment for it. And you as the clinician can submit that referral form for them. I do want to point out that Maryland actually has commented on their experience, like the Maryland Department of Health, and has noted that they have had a lot of patients drop out, as in they'll come in for their first dose and then they don't come back for the second or third dose. So I would very strongly recommend that if you are going to go down this route for your patients, that you tell them hey, please make sure that you go for the second and third dose. And if you're able to follow up with them, just make sure that they're getting the second and third dose of remdesivir. I now want to move into viral rebound, which is the other hot topic with regards to COVID-19 and nirmatrelvir ritonavir treatments. So viral rebound is defined as after completion of therapy, that there's a recurrence of symptoms or there's a new positive viral test after having tested negative for COVID-19. And this was one of the first published articles on this. This was a letter to the editor in New England Journal of Medicine, where essentially they have these 3 cases where patients had symptomatic relief after going on Paxlovid, and then had recurrence of symptoms after stopping it. And in 2 of these patients, they actually were able to document negative PCR testing and subsequent positive PCR testing when symptoms returned. But I would like to point out that symptom rebound without treatment is something that has been going on for a lot of this pandemic. This is data that was published in JAMA, just showing that even in patients who don't get any treatment, who were randomized in some of the other studies to placebo arm, that they did have this period where they had resolution of symptoms followed by recurrence of symptoms afterwards. So this is something that may be not necessarily related to Paxlovid or to nirmatrelvir ritonavir, but may just be a phenomenon that we see with COVID-19. And then this is just further data showing that when they look at PCRs for this initial study of Paxlovid, that both in the placebo arm and the nirmatrelvir ritonavir arm, there was this decrease in viral load followed by this increase after day 10. And with that, I would like to put in a plug for a study that's being done by Dr. Mariam Ayub, Dr. Princey Kumar, and I'm also helping with it. It's a study looking at the efficacy and safety of different durations of nirmatrelvir ritonavir in non-hospitalized patients who are at least 12 years old, who have symptomatic COVID-19, who are immunocompromised. If you think you have a patient who would be a good fit for this, please feel free to email any one of the 3 of us, and we're happy to get them set up for it. And with that, I just want to summarize sort of the big take-home points of this talk. Influenza and RSV are at records high, likely being driven by the relaxation of our COVID-19 mitigation efforts. I really would like you all to encourage vaccination among your patients, and I hope that you now have some tools and talking points that you can mention to them with regards to especially influenza vaccination. Antiviral treatments are most effective when they're given within the first 48 hours, really the first 36 hours. And then immunosuppression and underlying cardiopulmonary disease put patients at higher risk for complications and severe manifestations of these respiratory viral illnesses. And with that, I would like to thank my family and the Georgetown Division of Infectious Diseases.